Welcome to lecture for psychopathology. This time we'll be talking about disorders related to eating and sleeping behavior. So starting off with the eating disorders, there are two major diagnostic categories in the DSM-4 right now for eating disorders, those being anorexia nervosa and bulimia nervosa. We'll start with the DSM criteria for anorexia nervosa. And say it the long way, anorexia nervosa, not just anorexia, because the word anorexia has meaning in and of itself that's distinct from the disorder. Anorexia means lack of appetite. So it's often a symptom of a variety of illnesses and disorders. I'll strive to say anorexia nervosa. Sometimes I'll slip back into using the shorthand, but when I say anorexia, I do mean the disorder, anorexia nervosa. Okay. The criteria. Criterion A is refusal to maintain a minimally normal weight for the person's age or height. So to determine if somebody meets this criteria, you have to know what their minimally normal weight is for their age and height. And usually what people use are those kind of growth charts that it's insurance companies that put them together for doctors that tell you what the average person for a given age and height is. And then the DSM offers a kind of heuristic of if they're whatever that number is, if they're 85% of that or lower, then that's too low and that meets criteria. But the 85% rule isn't written into the criteria as it has to be 85%. That's just given as kind of a guideline to help people identify when somebody's slightly underweight to seriously underweight to the point that it's consistent with anorexia nervosa. And again, it's not just being underweight. It's like, oh yeah, I'm trying to eat, but I haven't been able to gain weight. I was so busy, I haven't had time to eat. It's a refusal to maintain normal weight. So they're striving to be underweight, succeeding in refusing any efforts to bring them back up to a normal weight. To give you an idea of what the 85% rule would look like for a woman, an adult woman who's 5'5", she would weigh 105 pounds or less. So if an individual is maybe underweight but not severely underweight yet, so maybe they do have a minimally normal weight. They're on the edge. They think, oh, they're not there yet, but they have all the other symptoms of schizophrenia. Well, if they don't meet this criteria, then they obviously couldn't be diagnosed technically with anorexia nervosa, so they would most likely be diagnosed with eating disorder not otherwise specified. EDNOS. It's the catch-all category for eating disorder behaviors, symptoms that don't fit neatly into one of our two existing categories. Okay. Criterion B is an intense fear of gaining weight or becoming fat. And again, this is in the context of criterion A. So they are underweight, significantly underweight. It's still phobic, and it is phobic in intensity about being fat, becoming fat, or gaining weight. So a lot of checking behavior, weighing themselves regularly, a lot of obsessive thinking about weight. In a lot of ways, anorexia nervosa looks very much like an anxiety disorder, with anxiety being about weight and body. Criterion C, there's a disturbance in the way one's body's weight or shape is experienced, undue influence of body weight or shape on self-evaluation, or a denial of seriousness of current low body weight. It can be any of those to meet criteria. It could be more than one. The first one, the disturbance the way one's body is experienced, relates to this the idea of that people have this perceptual disturbance that typically they see themselves as being bigger than they really are. Right, bigger and fattier, having more fat tissue than is objectively there. More recently, research has begun to call into question whether or not this is really a valid diagnostic symptom for eating disorders. One, the methods we have for measuring perceptual disturbance haven't been very good. They're not very precise. You use a lot of silhouettes. Which silhouette looks like you, which one is your ideal you, and those silhouettes are pretty generic in broad measures of people's perceptions of their bodies. In addition to that, the control groups that we compare people to, we have individuals diagnosed with anorexia and individuals who don't meet criteria. And these individuals that don't meet criteria often show some level of perceptual disturbance as well. When we look at young women, and we do things like, okay, there's all these belts. Which belt is the one that fits tightly around your waist? And more often than not, most of them will choose a larger belt than is really necessary. So the perceptual disturbance seems to be somewhat normative. It may not be indicative and diagnostic of an eating disorder. Um, and some individuals with anorexia nervosa may know exactly how much they weigh and how big they are, especially how much they weigh. They usually have a very good idea of that. Uh, but they know how big they are, but they feel that it's too small. I'm sorry, that it's too big. So they can accurately sometimes estimate how big it is. Okay, spread your hands apart until you get to how big your hips are. Fairly accurate, but they say, then you say, well, how big should they be? And their hands will come together to some unreasonable portion that's not humanly sustainable. So it's more of an unrealistic expectation about what the body should be, and a lot of negative feelings attached to how their body is perceived, which gets into the second part of this, that undue influence. So, for most people, your self-evaluation, how you feel about yourself, is influenced by some degree by your appearance, and part of your appearance is your body's weight and shape. Right? For individuals with anorexia nervosa, and often in other eating disorders, that becomes the primary mechanism by which self-evaluation is determined. So if I'm small and I'm not eating, then I'm good and I'm strong and I'm powerful. If I slip and I eat, or if I gain weight, then I'm weak. I have no control, and I'm horrible. I'm worthless. I'm no good. So way too much influence, undue influence on self-evaluation with regards to body weight or shape. And the last one, denial of seriousness of current low body weight. So even though super skinny and dangerously so, quite often, no, I'm at a healthy weight. And sometimes you have people tell you, well, I'm a trainer, or I'm a nutritionist, and I know what a appropriate body weight is, and I'm at it. And and other medical professionals say, no, you're not. This is dangerously low, and it's not healthy. But that's part of the disorder. Is this belief that should be smaller, and that, or that if you're really small, that is the appropriate size. Criterion D, amenorrhea, which is a cessation of menses for 3 consecutive menstrual cycles, which is obviously only required in postmenarcheal females, so young girls who unfortunately exhibit the symptoms of anorexia nervosa. If they haven't had their period yet, they can't lose it, so but they can still be diagnosed with anorexia nervosa. But women who have had their period, if they don't have amenorrhea, then they don't technically meet criteria for anorexia nervosa, which is unfortunate, I think, clinically, because amenorrhea isn't so much a symptom of anorexia nervosa as it is a consequence. Right? When you starve yourself long enough and your body fat gets low enough, it leads to these hormone shifts, which leads to the amenorrhea. And we see some professional athletes experience the same thing because of their they have low body fat but high muscle content. So they're not underweight, but they just have low body fat because of their training regimens. But you can get the same thing by starving yourself. But if you haven't starved yourself enough, you don't meet criteria, which is kind of silly, given that if somebody is in the process of starving themselves in the context of what seems to be anorexia nervosa, it's anorexia nervosa. But technically, if they don't have this, you can't diagnose them, and so that becomes a problem sometimes with clients, because they read the diagnoses and the symptoms online, and they'll say, well, I looked it up and I don't have a problem. I still menstruate. I don't have an eating disorder. But really, they probably do if they have all the other criteria, and the eating disorder they would be diagnosed with is eating disorder not otherwise specified, right? Because it doesn't quite fit anorexia, but there's problematic eating behavior, refuse to maintain minimally normal weight, that fear of weight gain, and how they feel about themselves is tied into their body. Okay, that's an eating disorder. It may not be technically anorexia nervosa, but eating disorder, EDNOS. Last thing about diagnosing anorexia nervosa, you can assign a subtype, either restricting or binge eating, purging type. And this sort of people can get confused because a lot of people kind of try to make that the dichotomy between anorexia nervosa and bulimia nervosa. That, well, anorexia is about not eating and just people are real skinny. And bulimia, that's about binge purge. And generally that's true. But with a big exception here, people that binge and purge might have anorexia and not bulimia, right? If they have the refusal to maintain a minimally normal weight, it's most likely not bulimia, it's more likely anorexia. Even if they binge purge, it's anorexia, binge eating, purging subtype. So yeah, they can binge and purge. Often it's different than what it looks like in bulimia, smaller binges and longer periods between binges. But they still can get caught up in that cycle. And when they come up with these subtypes, the thinking was, well, these are maybe two different courses of this sort, two different kind of types of anorexia. And so by knowing the subtype, you know how to treat it. Not so much. It seems to be maybe not so much distinct courses, but maybe different phases. Because some people will be restricting type. They'll restrict for a long time, months, consecutive months in a row, and then they'll have a binge, and then get caught up in a binge purge cycle, and they'll look more like a binge eating purging type. So the same person can be two types. It's probably not two separate disorders. It's just different aspects of the disorder. Nonetheless, it is important to know what type it is potentially, because there's certain medical problems that are more associated with binging and purging than restricting, and vice versa. So it's good information, but it doesn't tell you as much as maybe we hoped it would tell you. Moving on to bulimia nervosa. Criterion A is recurrent episodes of binge eating as defined by two criteria. The first one has to do with amount of food and amount of time. In a set amount of time, eating an amount of food larger than what most people would eat during a similar period of time. And this is a little fuzzy, a little gray, right? Because like for me, I make a spaghetti dinner. I could eat probably 3 plates of spaghetti in 20 minutes, and that would just be me eating supper. Now, if my wife, who doesn't eat spaghetti as much as me or as fast as me, if she ate 3 plates of spaghetti in 20 minutes, that would be a binge for her. So there's some individual variability and there's some subjectivity in there. But the idea is it's a lot of food in a short amount of time. Now, sometimes people will binge and it won't be a lot of food. Like in other words, nobody would say, well, that's a lot of food, or boy, I could have done that. Somebody has 2 cookies over the course of a few minutes. It's like, hey, that doesn't take long to eat cookies. That's not a lot of food. That doesn't seem like a binge. And by DSM criteria, it wouldn't be a binge. But they may do that. It may trigger fears of being fat, and they may engage in compensatory behaviors by purging or doing something else. And so it looks very much like a binge-purge cycle. And so that's probably a subjective binge. It feels like a binge to the person, but doesn't meet DSM criteria for a binge. So if that's the kind of binge eating that they're engaging in, it wouldn't meet criteria for a binge episode in bulimia nervosa. So what diagnosis would you give them? Eating disorder not otherwise specified, right? That catch-all category where things don't quite fit, but it's still clearly a problem. So the second criteria for a binge episode, I think, is even more distinctive and definitive of what a binge is, and it's related to a sense of control. That there's a sense of lack of control, overeating during the binge, in more than the amount or the time. That's really, I think, what helps identify what a binge is. It's not just somebody who, I got really hungry. I think I'm gonna eat this whole sandwich. It's I'm really hungry. I don't want to eat. I've got to eat, and then can't stop eating until the food's all gone, or I'm painfully full, or somebody walks in, something stops you. There's just a lack of control, which is often frightening, right? We like to be in control of our behaviors. So then, following that usually is some compensatory behavior. So recurrent inappropriate compensatory behavior that's enacted to prevent weight gain. And somewhat ironically, most of the compensatory behaviors used by people with bulimia nervosa are ineffective methods for preventing weight gain. They just nutrition-wise, physically, they don't work very well for preventing weight gain, or especially for losing weight. And that's one reason why we see a distinction between bulimia nervosa and anorexia nervosa, with that refuse to maintain minimally normal weight that's present in anorexia nervosa. People with bulimia nervosa are of normal weight or slightly above average weight, because those compensatory behaviors aren't effective. Right? But it's important to remember that even though we say, well, they're engaged in to prevent weight gain, it's really often about more than just weight. It's about more than just body. It's about more than just food. Those are important concepts, important things to consider, but it's about more than that. And a lot of it is about emotion and emotion regulation. The compensatory behaviors people engage in might be things like self-induced vomiting, use of laxatives, diuretics, enemas, fasting, excessive exercise. Any of those things would be compensatory behaviors. Criterion C, so we put these things together. So binge eating and compensatory behaviors both occur on average at least 2 times a week for 3 months. Okay. So if it's less than this, if it's once a week for 3 months or twice a week for 2 months, again, don't meet criteria for bulimia nervosa, but it may still be a problem if it's a pattern of behavior and you've got these other symptoms. So again, that's another instance where you would apply the diagnosis of eating disorder not otherwise specified. So as you can probably realize by now, if you see somebody and their diagnostic label is eating disorder not otherwise specified, you know that they have some issues with eating, but that's about all you know. They could look more like kind of subthreshold bulimic or subthreshold anorexic. And you can't tell which from that diagnosis. You have to get more information. So the reason that there's this kind of time and amount criteria in here, unfortunately, because you might think, well, if anybody binges and purges, if you binge and you purge once, or just more than once, that's bulimia nervosa, right? No. Unfortunately, binging and purging is somewhat normative. Largely because dieting is very normative in our culture, and dieting is associated with usually restricted eating. It's not about eating a good diet; it's about eating consuming less calories frequently. And when you do that long enough, the body wants to correct, and it fires up its motivational centers. And when that happens, sometimes it can lead to overconsumption of food, right? Binging behavior, and then sometimes. So some section of people who then binge will then have negative feelings about the binge and will do something to get rid of it and will purge. And that happens for people who do not meet criteria for any mental disorder whatsoever. So some binging and purging is unfortunately normative. Maybe not normal, right? Maybe not healthy, but normative in terms of it happens enough that we aren't comfortable saying that, well, if you do it at all, it's a disorder. Okay, so there's some criteria has to happen a fair amount. Criterion D should look familiar. It's part of criterion C for anorexia nervosa, right? Self-evaluation is unduly influenced by body shape or weight. So same thing we talked about before. Now, importantly, criterion E. These symptoms do not occur only in the course of anorexia nervosa. Right? So if you have anorexia nervosa and you binge and you purge, it's anorexia nervosa binge purge subtype. It's not bulimia nervosa, right? Even if you meet criteria A, B, C, and D of bulimia nervosa, all 4 of those, if you also have refusal to maintain minimally normal body weight, fear of becoming fat or gaining weight, and amenorrhea, if you have those 3 other symptoms in addition to all the bulimia symptoms, it's not anorexia and bulimia. It's just anorexia nervosa binge purge subtype. Okay. But okay, so what if somebody has anorexia nervosa, binge eating, purging subtype, and then they start to get better, either because of treatment, just due to maturation. They start eating a little bit better. They still have some problematic eating behaviors, so they're still binging and purging, but now they're at 95% of the minimally normal body weight, so they don't meet criterion A. They have resumed menstruating, but they're still binging and purging, still undue influence, and they're still have a fear of becoming fat. Is their diagnosis anorexia nervosa binge purge subtype in partial remission, or is their diagnosis now bulimia nervosa? And the way to tell is to figure it out yourself. Unfortunately, the DSM doesn't tell you. There's no clear kind of answer as to how to determine that. It's left up to your clinical judgment. And you could, if you're a researcher, you'd probably look at things like, okay, well, other people in the family, do they have more of the markers that are consistent with anorexia or more of the markers that are consistent with bulimia, and try to figure out that way what this disorder is. As a clinician, you have kind of different motives and different rules, and so my recommendation is you think about a diagnosis as a lens, right? So if I look at this person through the lens of bulimia nervosa, how will that impact my treatment? And do I think they will get better? Do I think I can help them looking at them with that lens? If I look at them through this lens of anorexia nervosa and partial remission, and I treat them, how will that impact my treatment? And will I be able to help them? And whichever way I think will lead to a more positive outcome for the client, well, that's the lens I'm going to choose. That's the diagnosis I'm going to choose, right? Because you have some leeway there in terms of what's the appropriate diagnosis. Last thing about bulimia nervosa, it can be divided into two subtypes: purging subtype and non-purging. Kind of like with anorexia nervosa, the subtypes aren't as meaningful as we maybe thought they would be when they first developed them. Basically has to do with the type of compensatory behavior. The purging types are the vomiting, the laxatives, diuretics, and the non-purging are the excessive exercise and fasting, which again, people might engage in both. Some people might not be a pure type, or they may alternate between one type and another, depending on certain environmental inputs. Okay. Now there is another eating disorder in the DSM, not as a current diagnosis, but it's in the back under diagnoses to be considered for future research. Which when they do that, they're like, well, we think we want to put this in. We're going to put some criteria in so people will study it. They'll look at it in the clinic, and then if it seems like it's a valid category, we'll put it in the next DSM. So this is one that has a good chance of being in DSM-5, and that's binge eating disorder. Right? Currently, kind of some provisional or research criteria. It's basically bulimia nervosa without purging, which makes it not at all bulimia nervosa, but it involves just binge eating. So, recurrent episodes of binge eating, as again using the same definition of a binge as is used in bulimia nervosa in terms of the amount of food and the amount of time, and a sense of lack of control. Which really, again, it's that sense of lack of control that is so psychologically threatening, I think. And then some more criteria about the episode to kind of further define it, because you need more criteria to make sure you've got a robust disorder here. So three symptoms associated with the binge eating episode: either eating rapidly, more rapidly than usual, eating an amount of food until one feels physically uncomfortable, eating a large amount of food even when not hungry, eating alone because of embarrassment regarding the amount that one is eating. You don't want anybody to see how much you're binging on, and or negative feelings after overeating. So feeling guilty, feeling shameful, feeling depressed after the eating. The individual is distressed about about. It's Canadian for about the binge eating. So it's not just people that every once in a while I like to get me a large pizza, sit down by myself in front of the TV, and just eat the whole thing, and it's delicious. Now, this is people that again, there's a sense of discontrol, and they're bothered about the recurrent episodes of binge eating. And again, it has to be a certain amount. Occurs on average 2 days a week for 6 months. Again, because binge eating is somewhat normative. Right? For a variety of reasons, either because you miss a meal, or you're dieting and you just get too hungry, and then you eat more. When you get really hungry, you eat fast. When you eat really fast, you end up eating so fast that your body's satiety signals, the way your body tells you, okay, I'm full, stop eating, can't kick in until you've eaten more food than you needed to eat, right? Or also sometimes binges occur, related to emotional dysregulation, experiencing a negative mood, dysphoric mood, and you eat to feel better, right? And that happens outside the context of mental disorders. It's part of normal human experience. It only rises to the level of disorder if it becomes this kind of recurrent pattern where you're doing it a lot. And then we kind of rule out for binge eating disorder, it can't be the other disorders, right? So there are no compensatory behaviors. So they binge, but they don't purge, they don't exercise afterward, and don't meet criteria for anorexia nervosa or bulimia nervosa. In terms of the physical consequences of eating disorders, we know the most about anorexia nervosa and bulimia nervosa. For anorexia, dry skin, brittle hair and nails, cold intolerance, which is lanugo, which you get that fine downy hair on the trunk of the body, and heart problems. And these are things that happen when you starve yourself. And so some fairly serious health problems, but then also, ironically, a lot of the physical consequences are related to kind of a negative impact on appearance. I say ironically because part of anorexia is this disturbed body image, right, and wanting to look a certain way, and because of the efforts to look a certain way, they end up damaging their outward appearance in many ways. We'll see some of the stuff with bulimia as well. At least if they engage in the vomiting, they may result in enlarged salivary glands, right, which will lead to a chubby face appearance, which again is often counter to what they're hoping. Erosion of dental enamel, also if they're vomiting. An electrolyte imbalance, and this can happen with any type of purging. Moving lots of liquids out of the body quickly can be problematic, which eventually can lead to cardiac and renal problems, so potentially serious outcomes there as well. If we look at the epidemiology of eating disorders, anorexia nervosa and bulimia nervosa, about a 1% prevalence rate, whereas binge eating disorder seems to be more common, as high as 5%. The peak prevalence is in the late 20s for women. At least that whenever it's identified, right? The disordered eating behavior and disturbed body image is present usually well before that, and we can identify disturbed body image in disturbingly young children. And eating disorders are being diagnosed in children younger and younger. That's kind of a trend. And the other trend, we have younger kids being diagnosed, but we also have this group of postmenopausal women now that anecdotally some people are reporting in their clinics seeing more women, postmenopausal women, reporting with eating disorder behavior, especially anorexia nervosa. So we'll see what happens with the epidemiological data over the next couple of years. The gender ratio for anorexia nervosa and bulimia nervosa, 10 to 1 female to male. So it does happen in men, but rare, maybe 10% or less of the cases. And when men have disturbed body image, what seems to be the case is it's not so much about being thin or being too big. It's about being too small, not a big enough stature, or not muscular enough. And that's where you see the guys using human growth hormone and steroids. That behavior, where they're using steroids and super pumped up and the zits everywhere, that might be an eating disorder, a body image disorder for men. That might be the manifestation in men. Research still ongoing, trying to identify exactly the boundaries of those things. Your book talks about there are subthreshold eating disorders in 10% of young women in the U.S. I'd say that's a low estimate, especially having worked in a university counseling center. I'd say subthreshold is closer to 40%, at least in like a college population. I'd say it's very common to have disturbed body image, dissatisfaction with body image, fear of becoming fat, and some binge purge behavior, and also some restrictive eating, which starts getting into anorexia nervosa. So a common problem. In terms of comorbidity, high rates of comorbidity with eating disorders, most often anxiety and mood disorders. And when anxiety disorders are present, often, not always, but often they precede the eating disorder, so they may serve as a risk factor for eating disorder. So being anxious and generally having an anxious disposition might contribute to that fear of how people are evaluating you, fear of becoming fat. Right, makes sense. Whereas mood disorders, most often major depressive disorder, occur after or during the development of an eating disorder. So feeling bad and shameful about what you're doing or about not being successful at controlling your body image, contributing to depressed mood seems to be the case. Okay, if we look at the progression of eating disorders, theoretically, for anorexia nervosa, often starts with dieting, right? Restrictive eating. And one thing we see is people get positively reinforced for weight loss. Oh, you look so good. You're doing great. And so, well, if losing this much is good, losing more must be better, right? Because that's how reinforcement works. Whatever is reinforcing, you do more of. Dieting and the positive reinforcement people receive from successful dieting may play a role in the progression of anorexia from just dieting behavior to disorder behavior, if a lot of other things are present. Because again, a lot of people diet, and the majority of people who diet don't develop anorexia nervosa. Right? Bulimia nervosa, in terms of what triggers a binge, sometimes it's restrictive eating. So people that try not to eat, and then they just get really hungry, and then can't help it, lose control, eat a whole lot. Right? And then once you eat a whole lot, it's not, oh, I feel better. It's, oh my God, what have I done? Because again, I've been trying not to eat, so now this is a personal failure, some indication of my worth as an individual. I'm weak and stupid and lazy, tell myself all these horrible things. I've got to get this out of me. So I'm going to throw up. I'm going to, get on the treadmill for 6 hours, whatever it is. And you compensate, you purge, and there's an immediate feeling better, like, that feels better. But then after that feeling fades, and then there's this shame. Oh my God, what did I just do? I was trying to diet. I pigged out, and then how gross. I went and stuck my finger down my friggin' throat. And this kind of, a lot of shame develops related to the binge purge cycle. And it's usually pretty secretive. Not telling people about it. And then it starts over again. I feel so bad. I feel so bad. Oh, how could I feel? I don't know. I feel so horrible. I'm just going to have a couple of chips. And then binging again. And then purging again. Binging it, right? And it gets caught up. Sometimes binge eating is preceded by a period of restrictive eating. And in this way, sometimes people with bulimia nervosa look kind of like failed anorexics. Right? So they may have a fear of being fat, and they don't want to eat, but they have some difficulty with impulsivity, less perfectionism, less self-control, and will then end up binging and not being able to be below weight. But sometimes for some other people, and also for some of the same people at different times, binge eating may not be triggered so much by restrictive eating as it is by dysphoric mood. And dysphoric just being negative mood. So anxiety, sadness, anger, feeling bad, eating to feel better, and eating a lot to feel better. Right? And that's pretty common in bulimia nervosa and eating disorders in general, in terms of using food not as a source of nourishment, but for other purposes. And then the same thing happens with binge eating disorder. Again, they're not typically restrictive eaters, so their binge eating is more likely to be preceded by dysphoric mood, and sometimes even just boredom. Looking at the etiology of eating disorders, if we look at the social dimensions, obviously the cultural attitudes come into play. In the West, Western cultures, we have the thin ideal, that beautiful is equated with thinness. Therefore, more thin is more beautiful. Right? And lots of evidence regarding this in terms of prevalence of eating disorders higher where in more westernized culture, where cultures subscribe to the thin ideal, and not all cultures do. Some cultures, their idea of beauty is less related to thinness and more related to other attributes, often still physical, but different physical attributes. And even in our own culture, it's changed over time. right? So, and it's for many years it's changed in kind of a negative way, where they talk about the average waist size of Miss America contestants and how it's been shrinking over the years. We think about that as a paragon of beauty, which I'm not sure we should. But people at least in our media that we uphold as these beauty ideals, have gotten smaller, right? And that contributes to, sets the stage for eating disorders. And again, not everybody who sees who's in that culture is going to develop eating disorder, but it is a risk factor, right? And it is a problem. And just kind of one piece of evidence about that, one of the more dramatic pieces, is whenever we introduce Western culture, when we export our culture places, when we're trying to export our goods to increase our economy, one of the things that we export usually is psychopathology, especially eating disorders. In Fiji, we introduced television, and they saw Western TV shows, and all of a sudden, rates of eating disorders in Fiji skyrocketed. You're welcome. So culture definitely does play a role. Exactly what the role is, not sure. Perhaps more importantly, culture at a smaller level, more intimate level, peer attitudes and peer dieting behavior are strongly predictive of eating disorder behavior. So people whose friends all think that skinny is good, that fat is bad, that fat is ugly, and the friends are always dieting, those people are more at risk for developing eating disorders, as are their friends, obviously. But just having friends who think that way and do those things puts you at risk. Right? And there's certain peer groups where those attitudes and behaviors are the norm. So think about ballerinas and gymnasts, where they're often told to be smaller for their activity, for their sport. Higher rates of eating disorders in those groups than in women who aren't in those groups. And then also family variables. For anorexia nervosa, it seems to be in the literature the family is characterized more as being enmeshed and controlling. Right? So the person with anorexia nervosa theoretically is thought to be pushing back against all that control. Okay, you can tell me when to be home. You can tell me I have to go to school. You can even tell me what I have to wear, but you can't make me eat. You can make me sit at the table for hours. You can make me put it in my mouth, but you can't make me swallow. I'll spit it out. I'll hide it. You can't control me. You can't control that. And that certainly does seem to be the case for many people with anorexia. Not all, but many. In contrast, bulimia nervosa, kind of the opposite. The family is more often described as being disengaged than enmeshed, and conflictual, hostile family dynamics, which again makes sense if you think about the binging and purging being a way of dealing with negative mood states, because you think negative mood states would be more common, and you wouldn't learn healthy ways of dealing with negative mood states in this kind of disengaged, highly conflictual, hostile family setting. Individual psychological dimensions, there are multiple. We won't talk about all of them, just touch on a couple. Perfectionism, which seems to be more associated with people who are restrictive eaters, people with anorexia nervosa, especially restricting, who are mostly restricting subtype, that they're hold themselves to unrealistically high standards in a variety of things. So in their schoolwork, in their if they are in a sport, whatever, across the board, they feel the need to be perfect, and often don't feel that they are perfect, and that there's kind of this very negative self-esteem paired with unrealistically high a high bar that they set for themselves. Whereas people with kind of the binge purge cycle and more of a kind of bulimia nervosa type individual, more often characterized by impulsivity. Right? So difficulty inhibiting impulses. And again, related to eating, but also in relationships, sometimes related to decisions about other risky behavior, like using alcohol or other substances. And then the other one, which applies to both, a little bit more for bulimia nervosa than anorexia nervosa, but really both eating disorders here. Emotion dysregulation and low tolerance for negative mood. So we all learn ways of regulating our emotions, right? When you feel bad, there's certain things you can do to feel better. And sometimes it's as simple as, well, if I just remember the good times, right? You have cognitive strategies. I'll think about this. You have physical, well, I'll go and do this. I'll spend time with this person. I'll call this person, right? And if you're feeling good, you have strategies for how to keep feeling good. Right? Those are your emotion regulation strategies, and they may not all be. Most of them probably aren't conscious, aren't overt. Where you, oh yeah, I know exactly what I do. You just do it. Some people don't have very good strategies, and also may have some biological differences that make it more difficult to regulate their emotions. And eating behavior comes in as kind of an inappropriate coping mechanism for regulating emotions. And then also the tolerance for negative mood. Everybody feels bad sometimes. Some people can stand it longer than others, right? Somebody, oh, this sucks. I feel like crap. But it will pass. I'm just going to suck it up. So I'm not going to try to feel better. I'm just going to wait till I feel better. And I can handle this. I can handle feeling bad for a while. I felt bad before. I'll feel bad again, but I'll feel good again. Some people, when they feel bad, it's intolerable. I've got to do something to stop feeling this way. And if I got to do something to stop feeling this way, that often leads to some form of pathology, be it eating disorder, substance abuse, thinking about cutting with borderline personality disorder and other personality disorders, antisocial personality disorder, some of the acting out that we see because people can't stand feeling bad. In terms of biological dimensions, like everything else, genetics play a role, but like most things, there's no flashing sign saying, oh, it's these genes, but it certainly does play a role, not surprisingly, because it plays a role in everything else. And then in terms of neurotransmitters, serotonin and dopamine, the two things that are most often talked about. Serotonin plays a big role in appetite, and some anomalies have been found in individuals with eating disorders and their family members related to serotonergic functioning. So that's the primary candidate in terms of what might be happening differently in these individuals. But then dopamine probably also plays a role because dopamine is involved in the reward centers of our brain, and eating triggers those reward centers. But like most things, they don't know exactly how it works, and there are no, even though they think, well, serotonin plays a role, you can't just give somebody an SSRI to treat their eating disorder. If they have comorbid depression, often they're given an SSRI to help treat that, but it doesn't treat the eating disorder per se. Last thing about etiology is just a recognition that there are generalized factors and eating-specific factors, right? So across all these dimensions we just talked about, there appear to be some risk factors that are common to all eating disorders, and perhaps common to psychopathology in general. So there's the generalized risk factors, but then the other risk factors that may be associated with the different manifestations of eating pathology, more eating-specific factors that might help you figure out, okay, well, if this happens, they're more likely to be a restrictive eater, and if this happens, they're more likely to binge purge. But still teasing apart exactly which things fall into which specific factors. Okay, now let's move on to the sleep disorders. So before we talk about the disorders, let's talk about normal sleep. So generally, when you sleep, you cycle between non-REM and REM sleep, right? REM being rapid eye movement sleep. So non-REM can be further divided in other stages, right, where you go from this kind of light sleep, which transition from wakefulness to sleeping, to progressively deeper levels of sleep, where you have these brainwave patterns that are fairly stable within each stage and reliable and repetitive. And then you go into REM sleep, and your brain waves go all over the place, and you have your crazy dreams, and you experience some paralysis where you can't move, but you're asleep, so you don't notice it. And then you go back into non-REM, and you cycle back and forth throughout the night, right? But generally, you feel tired, you lay down, pretty soon you start drifting into stage 1 non-REM sleep. You get more and more sleepy, and then you get to a deeper sleep, and then you cycle through without waking up for 6 to 8 hours, and then you wake up in the morning, coming out of non-REM sleep, and you feel refreshed, normal sleep. Right? So, in terms of the amount of time spent at different stages does change with age. So the amount of deep sleep you get changes, and as well as the amount of total sleep you get, and that's a kind of a normative change. But then also the amount of deep sleep you get changes with sleep deprivation. Right. So if you pull an all-nighter, stay up cramming for an exam, the next night you may not sleep longer, but more of your sleep will be stage 3 or 3 and 4 sleep, to your body trying to make up for what it needs, which unfortunately it can't ever do completely. Okay, so the sleep disorders. Breaking into 4 big categories. The one we'll talk the most about is primary sleep disorders, which primary sleep disorders are the ones where the sleep problem is not due to something else. It's not due to another mental disorder, not due to a medical condition, not due to a substance. It's due to something going probably wrong biologically, right, in terms of your circadian rhythms, and also poor sleep hygiene, some combination of those things, and it's what's of primary clinical interest. Okay. And the sleep disorders can be divided also into subcategories of dysomnias, which involve difficulty getting enough sleep, either not falling asleep or waking up too early, and or not getting enough quality sleep. Right? So crappy sleep. Whereas parasomnias involve abnormal behavior or physiological events that occur during sleep, so nightmares and sleepwalking, which parasomnias can lead to crappy sleep sometimes, but not always. Okay. And if you have a parasomnia, and so if you're having recurrent nightmares, and that's keeping you from sleeping, contributing to insomnia, it's not primary insomnia, it's nightmares. Right? Because it's clear that that's what's causing the problem with sleep. We're not going to diagnose it twice. So we have primary sleep disorders. Then we also have sleep disorder related to another mental disorder. This is when some mental disorder is thought to be the cause of a sleep problem. But it's not uncommon for disorders to have sleep problems in their criteria. I think about major depressive disorder. You can have insomnia or hypersomnia as a symptom, as part of the criteria. Right? But we only add, insomnia or hypersomnia as another disorder in the context of something like depression, if that the sleeping problem is of primary clinical interest. So, your insomnia is clearly due to depression, but it's really a problem for you. So we're going to put it on the chart for a diagnosis, because it's going to be targeted treatment. Okay. And usually, it's involving either a mood or an anxiety disorder. You can also have sleep disturbance due to a general medical condition, or is an identifiable medical condition that clearly causes the sleep problem, and then substance-induced sleep disorder, which usually it's alcohol, really jacks up your sleep. Okay, looking at the primary sleep disorders, if we look at the dysomnias, which again, not being able to go to sleep, problems getting quality sleep, that kind of thing. Excuse me. To be diagnosed has to cause clinically significant distress or impairment. Right? And for primary insomnia, which the primary is put there to distinguish it from the symptom of insomnia, right? You experience 1 month or more of problems initiating or maintaining sleep, so can't go to sleep or can't stay asleep, or a lack of restorative sleep. So maybe you have no problems going to bed and you stay asleep, but you wake up tired all the time. That would still be considered insomnia, with the assumption being that you don't know that you're waking up. Right? So problems initiating, maintaining, or lack of restorative sleep for a month, and it doesn't occur exclusively in the course of one of the other disorders or parasomnias, right? So it's not narcolepsy, it's not breathing-related sleep disorder or circadian rhythm sleep disorder. So there's not some other sleeping problem causing the insomnia. It's just insomnia. Which primary insomnia often involves kind of this vicious cycle where there's some initial sleep disruption, which often has some biological input, but then you engage in certain behaviors because of that, and those to try to well, not to fix it, but because you're so dang tired, you do certain things, and the behaviors that you start to do contribute to the maintenance of the sleep disruption. So you can't sleep. Oh, I'm so tired. I think I'll take a nap during the day. So now you start taking these daytime naps. It's going to perpetuate the difficulty falling asleep at night. And there are other behaviors too that involve kind of poor sleep hygiene that can develop in response to an initial sleep disturbance that can exacerbate primary insomnia. And also, it's important to note there's usually a lot of anxiety about sleep. And I don't know if I'm going to go to sleep. Hope I can go to sleep. And that anxiety gets in the way of sleeping. It's one of those things where you have to be able to tell people, don't try to go to sleep, and you'll go to sleep. Right? As long as you're trying to do it, you can't do it, which is really hard to not try to do something that you really want to do. Primary hypersomnia, the opposite. So we have 1 month of excessive sleepiness, and again, it doesn't occur exclusively in the course of another disorder. So it's not, well, I'm really sleepy because I can't sleep. Well, if you can't sleep, it's insomnia. This is you're sleeping, but still excessively sleeping. Excessively sleepy, so sleeping longer than you should, taking naps even after getting a full night's rest, that type of thing. Narcolepsy involves irresistible attacks of refreshing sleep. So it's not that, well, I lay down to go to bed at night and I suddenly go to sleep and it's refreshing. No, it's I'm sitting talking with some friends, I get kind of quiet, and the next thing I know, I'm asleep. And maybe a few minutes later I wake up and I feel refreshed, which is kind of nice, but you might miss out on some cool stuff, right? And the other thing, which is sometimes more disturbing to the individual, more bothersome, is the experience of cataplexy. So bilateral loss of muscle tone. So they fall to the floor, and it occurs sometimes when they feel certain strong emotions, anger or surprise, or even laughter. So that you tell a funny joke and they start laughing and then fall to the ground. I can also experience with narcolepsy elements of REM sleep during the sleep-wake transition. So either as you're falling asleep or as you're waking up, you're supposed to be in stage 1 at that point, which is non-REM sleep. But people with narcolepsy seem to have these REM events and things that happen in REM, kind of dream behavior, and also paralysis. So you can have paralysis, so be waking up and you can't move, and that's pretty scary, sleep paralysis, or hallucinations, hypnagogic hallucinations, where you'll, as you're falling asleep, you think you'll see something or hear something, and that can be disturbing as well. Breathing-related sleep disorder, obviously sleep disruption due to some sleep-related breathing condition, usually something like sleep apnea. It's where you're not breathing right, getting some blockage or what have you, where your brain's not getting enough oxygen, so it wakes you up, thinking, oh, you're going to die, wake up. But it might do it at a very kind of low level. You don't even realize you're waking up, and you wake up multiple times throughout the night. And so you'll be very tired when you wake in the morning. So you might lack that restorative sleep. So it's one of the things you're going to rule out. Is this primary insomnia, or might they have a breathing-related sleep disorder? Let's figure that out. Put them on a CPAP machine, something like that. Circadian rhythm sleep disorder. This is a sleep disruption due to the mismatch between basically environmental requirements and your circadian sleep-wake patterns. So your biological clock, is set to go to sleep at a certain time and wake up at a certain time. Sometimes we try to tell our bodies, nah, I'm not going to go to bed now, I got to go to bed now. And it could be the fact that your body wants to stay up later and sleep later. Your body isn't tired until 1 a.m. and then wants to sleep till 10 a.m. but you got a job that starts at 8 a.m. Now it's a sleep disorder, right? Because you can't get your body to do what you want to do, right? So you could sleep just fine if you could go to sleep at that time, but since the environment says no, you can't. Usually, if you don't have this disorder, you can train your body to go to sleep at a certain time, wake up at a certain time, and be fine. But some people have difficulty doing that. So it might be that, which is a phase shift subtype. Um, Also happens with people who travel, and you have jet lag type. Everybody's had that, or shift work type, which I can hear from experience sucks. Whenever you maybe work from 11 at night to 7 in the morning, trying to get your body to then sleep during the daytime when it wants to sleep at nighttime. If you can't get it to that, or if you're like some shift workers, where you change shifts repeatedly and you can just never get back to any kind of normal sleeping pattern, that would be a circadian rhythm sleep disorder. The parasomnias, again, so weird stuff happening. Sleepwalking disorder, obviously sleepwalking, so walking while asleep. And the person, if you wake them, which you're not going to, there's that myth, never wake a sleepwalker. You're not going to hurt them. They'll be fine. They'll be unresponsive when you wake them. Or they'll be unresponsive during the event. You call their name, they won't say, what? They won't talk to you while asleep, usually. And then once they awake, they'll have amnesia for the event. They won't know that they've walked somewhere. And there's also nightmare disorder and sleep terror disorder, and I put them together because it's important to be able to distinguish between the two. One involves nightmares, and the other involves sleep terrors. So a nightmare is a bad dream. So this is when you have waking during REM sleep, because that's when dreaming occurs, and you recall disturbing dream material, right? Or at least that, I don't remember the details, but I had a bad dream. It really scared me. Geez, that was weird. But you're quickly oriented. You know where you are. Oh, you wake up. I'm in my bed. Man, that was scary. But it happens a bunch. If it happens enough times, it might rise to the level of criteria of a disorder, nightmare disorder. Whereas night terrors, you wake up during non-REM sleep and usually wake up screaming, and you're disoriented, unresponsive. And usually it'll freak out whoever's with you, either if somebody's in bed with you or if it's a kid. The parent will freak out and like, what's wrong? What's wrong? And the kid won't say anything. They'll be unresponsive, and they have to be shaken awake because they're still asleep. And if you don't bother them, they may very well go back to sleep. So they'll scream in the middle of the night, lay back down, and they'll be sweating, right? But then they'll lay back down, go right back to sleep. And once you wake them, though, it takes a while for them to know where they are, what's going on. They'll be disoriented, and then you say, "Did you have a bad dream?" No, and there'll be no recollection of any dream material because again, they weren't in REM sleep. So it seems different than a nightmare, but also not the same as a panic attack. Subjectively different than those as well. Some other weird neurological event. Okay, sleep disorder is related to another mental disorder. When people go to sleep centers for insomnia, right? Well, yeah, geez, doc, I can't sleep. I need some help. A significant portion of those, 35 to 40%, meet criteria for sleep disorder related to another mental disorder, where they have some other mental disorder, and it's clear that that mental disorder plays a role in the etiology of their insomnia. And sleep problems in general are highly comorbid with psychopathology, depression, anxiety, psychosis. Whenever things aren't right in your mind, it's difficult to sleep. Right? Most often, though, when we see comorbidities, especially where the disorder is thought to be causing the sleep disturbance, they're mood disorders, anxiety disorders, and then substance-related disorders. So it makes sense that having these disorders will screw up your sleep. But what people are starting to realize more and more now is that it can work the other way too, and that sleep disruption is a risk factor for psychopathology, and sometimes that may explain how other patterns of comorbidity develop, where somebody may have one disorder, uh, um, an anxiety disorder, let's say, and let's say it really screws up their sleep, and that sleep disruption may then contribute to the development of a mood disorder. Right? So the psychopathology can cause problems with sleep, but sleep can also cause problems with psychopathology. Sleep is hugely important to healthy psychological functioning, and even though we've been studying it for a long time, it's still fairly mysterious, especially REM sleep. Exactly what the purpose of it is, we don't know. We do know if we deprive you of sleep long enough, you can develop psychotic symptoms. So we figure sleep's probably good for you. But exactly how it's good for you, why it's good for you, and how much you need, still working on it. Okay. But as a general rule, develop good sleep habits, get good sleep if you want good psychological health. Okay. That's all for now. Take care.